HSAT. I am transitioning off the board. We have a great new board starting at the beginning of May. For those of you who are not familiar with HSAT, we are a multidisciplinary 501c3 run by students, and our students come from all health professions from a lot of different schools across Georgia. So I thought we could start. I would just like to hear what schools we have in the room right now. Is mine just shouting out what schools you're from? Mercer School of Medicine, right?
Yeah.
Okay.
Morehouse
School of Medicine.
Emory School of Medicine.
Emory School of Medicine.
School of Public
Public Health, nice. What else we got? Life University, awesome.
Rollins School of Public Health.
Rollins School of Public Health, welcome. So as you can see, we are not a student organization. We're really unique in that way. We're not rooted in one school, and it allows us to be a lot more flexible, and it allows us to engage with each other as peers and collaborators and colleagues in a really unique way. So welcome, we're thrilled to have you here. For those of you who are interested in helping with events like this or with some of our other programming that's going on, come and talk to us. Can we have our current board members and oncoming board members stand up? Yay. So if you are interested in joining our board, we have several spots that are still open and that kind of already have a role carved out. If there is something else that you think you could bring to our organization, come and talk to one of us. Come and talk to one of our board members. The beauty of our organization is that we are very flexible, and one of our main goals is to promote students in leadership positions. So we want good people on our board. So we're happy to have you all here. I'm especially really excited to be here in this building. I graduated from the School of Public Health here at Georgia State last summer. And our board at HSAT has really been focusing on broadening what people think of when they think of a health professional student, especially to include public health. So I was very proud to be the first MPH president of HSAT, and I am delighted to be here hosting the School of Public Health at Georgia State, my home school. And also here to welcome us to the School of Public Health is Dr. Rodney Lynn. Dr. Rodney Lynn serves as Associate Professor and Associate Dean for Academic Affairs in the School of Public Health at Georgia State University. His research focuses on childhood obesity prevention, school and community health, and the reduction of health disparities. He has special interest in identifying effective policy and system approaches to increasing physical activity and healthy eating in children, and has published numerous peer-reviewed articles over these topics. And we're thrilled to welcome him up to the podium to welcome us to the School of Public Health.
Thanks, Leah, so much for having me. It's a real pleasure for me to be here and to have you all from so many of our partner institutions here. I just want to maybe say a word about Georgia State and the School of Public Health and some of the things that we have going here. And then I understand the meeting today is really focused on health equity. So I want to talk about that just briefly. I think HealthStat is a very important organization, and I've had the pleasure of working with HealthStat over a number of years, and just really helping students to sort of direct their energy and passion towards the changes that they want to see as it relates to health and healthcare. I think is critically important. You've really come to Georgia State at a really exciting time for us. It's really a time of growth, both at the university as well as in the School of Public Health. You may know we recently consolidated with Georgia Perimeter. We have over 50,000 students now at Georgia State. The School of Public Health is also growing both in terms of number of students, number of faculty, academic programs, and research. And so we have a lot happening. One of the things that's unique about Georgia State is our student body. We're one of the most diverse student bodies in the country. And one of the commitments we've made here at the university is success, is to really ensure that students from all backgrounds are successful. And one of the things that we do, and we've got some national attention for, is to really intervene to ensure that students persist and progress towards graduation. And so we use advanced analytics to really understand when a student is getting off track. And there are all sorts of markers that flag a problem. We have different responses to that. It may be a small loan, it may be academic support, it could be advising to get them in the right course. And ultimately what we're doing here is prevention. And so in public health, that's really our focus is prevention. And, you know, if we can make a commitment to health inequities and health disparities in the same way and figure out what those pressure points are and the levers that we can intervene there as well. And, you know, I think we know the social determinants, but we need more action. And so I think the very work that we're doing in university, there's some lessons there in our mission in public health and our focus on prevention. The topic today of health equity is one that's near and dear to my heart. This is an area that I've been very interested in and increasingly doing more work in this space. When I think about health equity, I was a couple days ago thinking about what I might talk about, and three things jumped into my head. One of them is water, clean water. And the Flint crisis really, I think, makes this so clear and a pressing issue that access to clean water is a critical issue, and we maybe take it for granted that everyone has clean water, and that's just not the case. And so water was one of the things. Food. I do a lot of work around obesity and food access, and so I thought, well, surely everyone should have access to clean water. Surely everyone should have access to healthy foods. And the third thing was surely everyone should have access to healthcare. So, those strike me as three, and there are more, but those strike me as three very fundamental requirements for health. And it's a sad case that we don't have that to the degree that we need in our country. And even here in Atlanta, we've got 35 food deserts inside the perimeter. We know that there are many states that have not expanded Medicaid. We know that we have millions of people that don't have access to health care. And we know that access to water continues to be a challenge. So, I hope we would agree that, these are things that everyone should have access to, and, that we're all working to ensure that that happens, both here in the state of Georgia as well as nationally. I just, really want to talk very briefly, 3 or 4 minutes about a project that I'm working on. It's funded by the Robert Wood Johnson Foundation. For some time had an interest in health disparities, and this project is really looking at the South specifically. I mean, if we think about health inequity and health disparities, I think most of us would agree that the southern region of the country is where there is a disproportionate burden in terms of health outcomes. And minority communities bear a heavy burden there as well. And so one of the things that I wanted to do, I don't know if anybody's familiar with the county health rankings. Robert Wood Johnson Foundation funds these rankings. They rank every county and every state on health. And so it focuses on both inputs as well as outcomes. And so I wanted to look at 10 states in the South and try to identify counties in those communities that are in the lowest third for income. So these are generally low-income communities. And they also had a diverse population, at least 25% African American, again, because we know that this is a place where there's a significant burden. And so the idea was, could I find sort of a paradox? Generally when you say low income and minority, you expect a very negative or poor health outcome. And I wanted to see if there were communities out there that had the story that was contrary to that had positive health outcomes, despite what we might think of as social and economic disadvantage. And so we looked at the data. Initially, I identified 17 of these counties. I submitted my proposal, it got funded, and they said, okay, now we need you to, I proposed I was going to drill down and really understand what were the factors that really were driving these outcomes. And, something interesting happened. We really started to look more closely at each community. And one by one, they fell off. We said, well, there are 4 counties in Mississippi, and when we looked at their health outcomes, we said, well, when we look at those health outcomes, maybe you ranked well in Mississippi, but relative to the national figures, it's not really a positive health outcome. It just says that most of the counties in Mississippi aren't doing well. So, we started to really look at the data more closely, and after it was all said and done, we had one community, one county in those 10 states. I've been to visit this community a couple times, done interviews there, looked at data, and the whole idea was, can we understand what are the factors that are sort of driving some sense of resilience, some ability to achieve positive health outcomes in the face of what you may think of as disadvantage. And so, I thought I'd talk just for a minute about 3 things that I found in this community. One is that there was a diverse representation. So in terms of the resources in the county and how they're distributed, there was fairly equal representation in terms of racial background of the leadership. So it suggested to me that issues of all residents are at the table, considered, heard. The other thing was access to acute care. We can't choose where our county is located. We can't necessarily choose where hospitals are located. But this community was located in an area that was convenient to specialized care. They also fund publicly provision for emergency and non-emergency transportation. So if you need to get to a physician, a doctor's appointment, and you don't have, it's a rural community, and you don't have a car, there's a means for you to get there. If you need to go to the grocery store, there's a means to do that. So we had a public transportation system despite being a small rural community. So, we don't always think about transportation in health, but maybe transportation is a critical issue. They had a very strong EMS system. It was a publicly funded county-based EMS system. Wasn't hospital-based, wasn't private. And so there's some things for us to think about there. And when you look at the characteristics of the EMS department, the level of care and the level of training that the staff had was at the highest level. The ability to have different EMS units within the county, so they were approximate to a majority of residents, was also important. Destination planning. There are a lot of things that more than I can go into here. And the third and final thing should not come as a surprise was that there was access to primary care for vulnerable populations. So people that didn't have or health insurance from an employer or Medicaid or Medicare, these individuals had access to primary care through their health department. Their health department at the time had a grant for the prior 6 or 7 years to provide primary health care for both children and adults. And I've been to a lot of counties, I've talked to a lot of people, and primary care in the health department is not standard practice. It's not in the state of Georgia, not in a lot of other places. There's not funding to be able to do that. So spending some time working with them, talking to the health department, both about primary care and other programs that they were delivering, was very, very helpful. It's an exploratory study, and so I don't want to suggest that what we learned in this county is is the answer. But I think we know that all the things that I found are important for health and health outcomes, and so so as you talk today about health equity, certainly access to health care, access to healthy food, access to water, access to specialized care when it's needed, primary care when it's needed, is critically important. And it's all of those are important causes that I know that this organization is focused on. We're delighted to have you here at Georgia State today, and we wish you the best with your need. So we look forward to having GSU students involved into the future, and again, welcome and wish you well with the day. Thanks.
Hi everyone, my name is Erin. I'm the education co-chair of HSAT along with Sydney in the back. And we're actually going to start our first panel right now. So if you're on the panel talking about educational efforts, you're welcome to come up here and grab a seat. So we have Project Quick Start, assessing outcomes for medical students involved in every pipeline program, and incorporating social medicine concepts into formal medical school curriculums. So first, we just want each person on the panel to go along and talk for about 5 minutes about what your project is and how it relates to addressing inequities through education. So we'll start with Dorit.
Hi everyone, my name is Dorit Beppo. I am a dual degree MD and PhD student at Emory. Erin and I are both representing medicine in society. And so I'll give you a little bit of background on how this all started and sort of where we are now in our current efforts to improve social medicine curriculum at Emory. So I guess starting in our first few years of medical school, when you're just in the classroom, we noticed that there was a pretty big divide in how they presented clinical outcomes and a complete, divorce of clinical outcomes from the social and economic conditions that lead to a lot of those outcomes. So they would talk about health, blood pressure, and hypertension is a lot worse in African American students, but wouldn't necessarily talk about access to food, things like food deserts, access to places of exercise that really modulate these outcomes and lead to worse outcomes in terms of obesity, mortality, morbidity. So Erin and Natalie actually, for our second year elective, decided to really get an understanding of what medical students in Emory understood about social medicine. So they conducted a series of surveys and focus groups to really assess the interest in social medicine. So things like social determinants of health, talking about how environmental access affects health outcomes, really getting a big, broad picture of what that looked like. And they found that although students were very interested, they didn't have much exposure. I think a lot of it was relegated to learning about it at grading, where you have a lot of patients who deal with social issues, economic issues, that really affect their health outcomes. But they weren't learning those things prior to getting to grading, and even after leaving grading, didn't have a full grasp of the language involved. Talking about social determinants of health and making it actionable. So our third year, after we finished rotations at grading, we were part of the social medicine elective. And as our project at the end of this elective, we wanted to develop an orientation program for first years. So right from the beginning, before they were exposed to any clinical medicine, to learn about social determinants of health, to learn about physician bias, to learn about and talk about different power dynamics that may affect your relationship with your patients. And we were able to work with some deans and some administrators, and our idea was sort of watered down and became a small part of the orientation program. And through those efforts, we realized that working with the administration is a slow process. So if we really wanted to engage students on our level and to really expose them to the things we were interested in teaching them, we would have to do this extracurricularly. So we began Medicine and Society. We were able to collaborate with another group of students that was really interested in service learning, and to combine our efforts, we drafted a proposal that then now is being implemented slowly to develop a 4-year service learning social medicine curriculum. So we're really excited that all of our efforts have sort of culminated in some slow curricular process, and it's helped that from the outside there's been pressure from the licensing board for medical education, the liaison committee for medical education, that there needs to be an emphasis on service learning, and there needs to be an emphasis on social learning. So it's really coalesced into something really great that we're excited about. And on the Medicine Society part, we've also been able to engage students, host different events like unnatural causes screening, which talks about social determinants of that. And we're just really excited about what we're doing so far.
All right, thanks, Lori. Our next panelist is Caroline. She's going to be talking about Emory Pipeline Program.
Hi, so I'm Caroline Matus, and I'm happy to be here to talk to you all about Emory's Pipeline Program. The Emory Pipeline Program is a multi-tiered mentorship and science enrichment program aimed at serving underprivileged high school students here in Atlanta. It was founded about 7 or 8 years ago by 2 medical students, and originally involved a cohort of 16 high school students, 16 undergraduate students, and 16 medical students. And the idea is that students would apply in the sophomore year for high schoolers and for undergraduates, and they would be paired into mentor-mentee pairs that would progress through the program together. Each year of the program would also involve a health science enrichment curriculum as well as a mentorship curriculum, kind of aimed at different things that thought to be relevant that year. So in the high school sophomore curriculum, we began with an infectious disease unit, also paired with a mentorship unit. They progressed in their junior year to a mental health and neurology unit. And then in their senior year, mentorship was focused more heavily for test prep and college preparation. There was also a public health unit to the program. Since the program began, it's expanded greatly. We now have 50 high school students, 50 undergraduates involved in the program, and not only are medical students involved now, but we have Laney graduate students and students in the School of Public Health who serve as the graduate student teachers, whereas the undergraduates serve more of a mentorship role for the high school students. Also, we're excited that in the past year we received a grant to kind of expand the scope of the program, such that it now involves 2 summer programs that kind of fit into the curriculum along with the school year program. So the students will be involved in a summer program before their junior year that is continuous with the curriculum that began in the sophomore year, and then once again after their junior year, they will be involved in the summer program before entering into their senior year. So we're really excited about that because it involves kind of a more continuous mentorship and enrichment opportunity throughout the school year and throughout the high school students' academic careers. Each year the program has done a review to look at outcomes for high school students and for the undergraduate students. High school students do report very high college acceptance rates and high scholarship funding rates. So many of the high school students have been able to go on to go to college with financial assistance, which is very exciting for us. The work I've been doing in the program is also looking at the outcomes for the medical student teachers and graduate student teachers involved in the program to see if it affected their interest in teaching and mentorship throughout their careers. So we surveyed all of the all the graduate students who participated in the program since its inception until the cohort that finished last year. And what we found is that those medical students reported that their experience in the program made them more comfortable and more proficient in teaching, and most specifically in one-on-one and small group situations, which they said benefited them greatly, especially once they became medical residents. And part of their duties is to teach in one-on-one and small group settings when they're on the wards. They also reported that the program exposed them to or helped them develop their skills as far as talking to patients and presenting diagnoses and treatment plans, looking at it from more of an educational sense than from a medical sense, and that their abilities grew to convey in a way that their patients understood what they meant and the lifestyle changes they need to make through the experience of teaching, because essentially that part of patient care is teaching. It's teaching what's wrong, what you can do to make it better. So we're very excited to see that. Also, our medical students reported they're more likely to engage in extracurricular mentorship and teaching opportunities in residency because of their positive experience in the pipeline program. So we're very happy with all the results we've seen so far on every level with undergraduates, high school students, and the graduate students. We're really excited to be expanding the program this year.
All right, our final panelist is Anisha. She's going to be talking about her project Quick Start.
Hey everyone, thank you so much for having us here. My name is Anisha. I'm from Mercer School of Medicine. So Project Quick Start is a pilot program that we started, and it was inspired from a community needs assessment I had conducted in my first year in medical school and working in the city of Decatur and Clarkston. So you can go online and find lots of statistics about DeKalb County, but when I was doing my research, two numbers really stuck out to me, and I'm going to share those with you. The graduation rate in 2013 was 58.9%, and the literacy rate was 80%. When I saw those numbers, I knew that what I wanted to target was education and the disparities in education, especially in the city. So I partnered with a local school. Well, first I had to kind of take a step back and, kind of figure out what was I going to do. I work with adults, with children, and I just think it's a whole lot of fun to work with children, especially seeing the high school drop rate. I decided to partner with an elementary school in the city of Decatur and designed about 7 modules. Each module corresponds to 3 components. So basically what we try to do is increase health education, so try to get these kids to understand the importance of health and nutrition. The second component is to inspire an early love for the sciences, and finally to enhance critical thinking skills. I'll give you an example of a module so it's better to understand what we do. One of the modules we have is based on nutrition. Try to give them like fun little names. So this one is what goes in my belly. Each module is about 30 to 40 minutes long. Starts with an attention grabber. This is just to kind of like hook the kids in, get their brain flowing. Then we move on to the main activity, which is usually a hands-on component, and then finally end with a take-home message. So for this particular activity, that's what goes on in my belly, the attention grabber. Basically, we have them, write down what they thought was a healthy snack and put it in a basket. After that, we went around and talked about, what the nutrition values are and whatnot. The main activity for this was to discuss my plate, just different food things and whatnot. And then after that, they had an opportunity to construct it themselves. So it was more of a hands-on component. And finally, the last thing was to create a food diary. That's just one example. A lot of other ones that we have focus on physical activity, sciences, critical thinking, math and engineering. We have one for astronomy and exploration. And then finally, the latest one we did was science fair. So this was kind of to, get them to come up with the science fair idea, go through what the scientific method is, all the vocabulary and whatnot, go through the whole process, and help them quick start a project for their science fair that they could enter in their elementary schools. That's just a quick overview. I'll be happy to take questions and share pictures and whatnot with you guys. And if you want to get involved with this project or take this into another elementary school, I'd be more than happy to help you do that.
Thank you. So first, we also want to open this up to questions. So HChat has a question that we wanted to ask the panelists, but as we're going through this, audience members, please think if there's either a question you have for all of the panelists, or if there's something you want to know a little bit more detail about for one of the specific programs that we talked about. So the first question that we have is related to LCME, which is what Reed mentioned prior. So LCME is this kind of large body that creates standards for medical students as they're going through their curriculum. And it tells you different standards that medical students are expected to have once they graduate. And based on all the projects that we talked about, these are projects that a student could apply to. It's not something that every single student in the school is involved in. And so what we wanted to know is, based on your experience with your projects, different either knowledge points you think that people involved have learned about, what are some aspects of your program that you think would be beneficial for all students in your school to be involved in, not just people who kind of opt in to be involved. So anyone can answer first.
So I think in our early efforts with Medicine and Society, especially our first and second year, there wasn't much, we weren't gaining much traction because it wasn't something that was required by the LCME. And I think a lot of the students who participated in the focus groups or who came to our events were really those who were self-selecting into it in the first place. They already had an interest, they already had some sort of background in public health or anthropology, or did some sort of social science in college that they were more aware of sort of what social medicine entailed. And in the last year, as I was saying, the LCME has added a service learning standard, and that has really helped our efforts take off. So now it's, you know, there's an emphasis that all medical students, once they graduate, should be structurally, culturally competent, and they should know how to deal with patients with differential access, deal with patients with different cultural backgrounds. So I think that's very important as we are treating people. We're not treating, you know, diseases. We are treating people with diseases. So
Yeah, so it sounds like kind of what's helped in terms of trying to bring this to more people is that this kind of higher body, which the administration responds to, is kind of pushing this and saying we need to have this. I think that's kind of a way to increase access to all students instead of those who are interested. Definitely. What about our other panelists?
I most definitely think, I mean, I've surveyed the medical student graduates and they agree that the program is very beneficial. I think for us, the fact that we have been able to expand the program starting from only 16 kind of medical students to now we have 40 medical students and other graduate students. It's difficult to get everybody involved because it's finite within the program for the high school students, but I think the expansions that we have made have been very helpful, and also it's raised awareness about our program within the Emory community. So I think that's also helped people to find other avenues of outreach to help mentor high school students and teach. And I think that just the awareness and the idea to go out and do it will be more beneficial for the larger student body.
I know something too I was thinking about with Pipeline is when you mentioned how students felt they were better able to talk with patients. I think that's something that could, if there's more practice with all students and kind of being able to communicate really complex topics to patients who maybe aren't able to read or haven't gone as far in school. So I definitely think that would be, in addition, that would be great.
Based on this project and what LCME kind of has skills outlined, I would definitely say teamwork. After being in med school and whatever field you're in healthcare or whatnot, you're always working in a team, and being able to contribute to that and being able to work with people is very important. So I think definitely focusing on that aspect while you're in school, any kind of graduate school, that would be beneficial.
Do any of our audience members have questions either about the program or just a question related to education that might apply to our panelists? And when you have a question, could you say your name and kind of where you're from?
Okay. Hi everyone. I apologize for my throat. I actually am a nursing student and I'm also the executive director for PNIS. So thank you guys for being part of the panel. I have a question about the social medicine course. Is this at Emory? This is Dr. Gordon's course?
The elective, yes.
Okay. I'm wondering, have there been any talks to integrate any reflectivity in terms of the course and really having students investigate their own privilege?
So I'm very glad you asked that question. I think in our early efforts, we wanted to really have students confront things like bias, things like privilege, and like what I was saying earlier about, you know, power dynamics of you as a young person often treating patients who are much older than you. And with this mandate from LCME about service learning, there's a required reflection component. And so that what I wonder is how they're going to bring in things like bias and privilege into the greater service learning curriculum, because I think that's something that's very uncomfortable. And I think even though we are physicians and we deal with uncomfortable things, there is a hesitancy, and this is me speaking from my perspective, I'm not speaking for the administration, but I think there's some hesitation to really bring those issues to the forefront. And I think Dr. Lekowitz, who's our staff person who's really taking this on, feels that that is critical to being a good physician. So I'm sure she's working to really incorporate it too.
And then kind of adding on to that, I'm involved in this group that it's a White Book for Black Lives, and they actually have a curriculum branch. And so I've been in contact with other students across the country who are trying to bring in these efforts within the curriculum into the larger curriculum. So at other schools, they do have kind of implicit bias training. It looks different at different institutions, but it seems like nationally this is something that I think different schools are going at different speeds, but there is, I think, a larger, at least, knowledge point of what is bias, and like as healthcare professionals, something we need to address with our trainees. I think where schools are in terms of implementing that, I think that varies very largely. So hopefully Emory will kind of move to kind of implement that in a strong way. That's a great question. Other questions we have for our education panel? We actually have one more question. Oh, do you have one? Sorry, I can't see. Oh, no, you can go.
Okay.
Can you see your name?
I'm a third-year professor, and I just had a question about the pipeline program. How do the students and the schools get chosen to be part of the program? Is there an application process, or how does that work?
So initially, the only high school involved was South Atlanta High School, and that relationship was initially begun because the medical student had previously taught at South Atlanta High School, I believe, and I think that's how the initial relationship got started. The high school students do fill out an application. Either medical students or someone else will go in the fall semester, and I believe they meet with science teachers and kind of pass on flyers and give information about the program, and they'll apply at that time. When we expanded to the other 4 schools, it kind of expanded the application process. So we now have some of the administrators of the program now go to the schools to pass out the flyers and get students to apply from there.
It's actually for
Anisha.
It's actually work with elementary students. I was wondering, how do you go about picking those students who are like are the most elite, or you pick just random group of students? Because I know elementary is where they start those students in like resource classes. Are those students like excluded, or do you choose students just based on different criteria?
So with this first phase of the project, it was choosing students randomly. So when we established this relationship with the school, we didn't have the luxury to choose students that we would work with. We had the option of working with 3rd, 4th, or 5th graders. So what I chose to do was work with 5th graders. And with that, we've completed the 7 modules. So next phase, we're trying to get more facilitators trained and bring this to 3rd and 4th graders as well. So it's basically, if you can think of like homeroom, before they all get split apart into special needs or wherever they're going to have a gifted class. So it's just a random mix of students, all competencies together.
We have another question for the panelists, and this is a question that we'll also ask our second panel, but we think it's very important. When you think about having these different initiatives within the community, are there certain either like background information that individuals would need to have, or specific training that that students should kind of experience before they kind of start an experience that is within the community? If you all can speak to that.
Pipeline in particular, I think no. I think the program benefits the diversity between its undergraduates, its graduate students, and the high school students as well. And I think that the benefits of the program, or teaching ability and communication, are built from the experience. And so I really think it's one of anyone who wants to get better in their ability to communicate and their ability to teach, which will play such an integral role in their ability to interact with patients and appropriately treat patients, should apply and benefit greatly.
I would say before going out into whatever community you're targeting, it's really important to get to know the people, the demographics, kind of understand the culture, the language barriers, because especially with Decatur and Clarkson, there's a huge population of refugees and a lot of immigrant families ranging from Syria, Afghanistan, India, Pakistan, and then we also have students mixed in from the States. So it's really, before going out into the community, just to make yourself aware of that is important. And if you're targeting a specific institution or a school, like an elementary school, I think it's definitely beneficial to have some training with that. With me personally, I went to a few trainings for the school in order to, interact with these kids. They wanted me to understand a little bit about child psychology, learn a little bit about education techniques. So I think it's very project specific, but one overall thing I would say is just get to know your community better so you can interact in a more efficient way.
I would definitely echo what Anisha just said. I think for some of our efforts that we're trying to do, that we piloted with the first year students is a neighborhood exploration activity, to really have all the different small groups that the first year students are working into to learn about and look up demographic information. What are the high school graduation rates in different neighborhoods in Atlanta, and really getting a broad sense of what Atlanta looks like, since many students are not from the Atlanta area or even from the Southeast. So really getting a better handle on what is out there, and then going armed with that knowledge to really try and get to know their patients better.
I think adding on to that is kind of where you're getting that knowledge from. So when we initially did our neighborhood exploration activity, students enjoyed it, thought it was great, but one area for improvement that we heard was we want to kind of get this information from people that live in the community. So we had students looking on the computer and looking up demographics, and then we also had them kind of going to a Kroger in different neighborhoods. And so in both of those instances, we hadn't really been, I guess, as thoughtful in terms of finding community partners who are already in the community. And I think moving forward, that was a big learning point for us, was kind of how you're learning about these communities. Who are the people who really know the community well, people that actually live there. So kind of being very purposeful in how you're seeking out that information, I think has been very helpful for us moving forward.
I think moving forward for the 4-year curriculum, really partnering with organizations in those neighborhoods and having them be the ones to teach the medical students instead of doing internet research. That way there's a face, there's a personal connection, there's an understanding of here are the human faces that these statistics apply to, and really connecting on that level.
Just kind of going off of what you're saying, have you thought about maybe putting a grant to the NIH for these CPR projects that would kind of help with the sustainability of the
Oh, no. That sounds good happening.
Okay.
Any other questions we have for our panelists?
So I guess about pipeline, I think something that's striking to me about pipeline is that it's like a longer relationship and that people have. So like a lot of those things that we talk about in terms of like the importance of learning from the community, that's inherently built into pipeline because you have this long-term relationship with schools. So I don't know if this is what my question is exactly, but I'm like, I guess how many, like what alternatives, how much is that an important part of what your students seem to take out of it? Is that they're learning a lot of these lessons about their, like the high school students' lives kind of minute by minute, day by day. And what part of that do you think is reproducible in other kinds of community health projects? If not everyone can do pipeline, like what are other ways that like similar kind of experiences give student lives in a problem?
So the mentorship component is huge, and you really do. I went to Emory undergrad as well, did pipeline as an undergraduate student, and had a mentee for 3 years. And it's, you really build a relationship with that person, and you begin to, as you progress through the 3 years, kind of your relationship changes, and towards the end, when you're thinking about colleges and test prep, things like that, you become so invested. You become so invested in, their college applications, proofreading their letters, things like that. And that's completely outside of, the educational curriculums that you're doing. And so I really think that even if not everyone can be a part of pipeline, there are plenty of other either unofficial or official mentorship programs to work with high school students. And I think it's a very meaningful relationship for both parties involved. And so I mean, mentorship is huge as part of the program. I think that'd be the avenue if someone's not involved in pipeline, but kind of wants to be meaningful in a student's life.
All right, well, thank you so much, panelists. That was a great conversation we had. We can give our panelists a round of applause. And before we have a brief break, we're going to have two of our 3-minute thesis presentations present their topics. Just for a quick overview, these are very quick, like I said, a 3-minute talk about a topic that the presenters have chosen. So our first one is going to be Natalie Stahl, and her topic is going to be "This Phone Number is No Longer in Service, Implication of Disparities in Phone Access."
Okay, so quick survey to start out. How many people in this room have had trouble keeping minutes on their phone, haven't been able to make phone calls in the past 6 months or so? How many people changed their phone number in the past 6 months? What about the past year? How many people have had the same phone number for 5 years or more? So that's most of us. So we talk a lot about in healthcare how privilege can kind of blind us, how there's things that we can't always think about other, what our patients might be facing. And phone access is one of those topics that I think is really relevant and that I'm going to talk about quickly. So this came about because I was doing my discovery project and I was working with patients from the Ponce de Leon Center, which is the grading HIV clinic. And I was working to kind of compare the experiences of people who've been well retained in care, who kind of have been in care for 2 years or so, and people who just coming back to care after a gap, who've fallen out of care. And one of the things I wanted to ask them about was their phone numbers, because I'm sure we've all experienced times when you try to call up a patient or you try to reach someone and their phone number is not in service anymore. So I was curious as to how common that was. And I found that it was really common for people who have a lot of social barriers to have a lot of instability in their phone numbers. So 90% of my participants had mobile phones, but almost a third of them, kind of fairly similar between retained and unretained patients, had trouble keeping minutes on it. And 66% of patients who had been unretained in care had a phone number change. Only 30% of retained people had a phone number change in the past year. And 38% of people who were unretained had more than one change in the past year, versus just 15% of people being well retained in care. And when I went to go look for studies about this, there was actually very little written about this kind of topic. There's a lot of things about text messaging patients, but not so much about people's phone number changing. There's one study by Ruth Parker's group, which is also here in Atlanta, looking at a WIC population, and they found that 7% shared cell phones, and about 25% had a cell phone number change at least once in the past 6 months. So this is a pretty significant number. So what do we do about it? Well, one thing is that you should always ask. When you're doing a history, if you have any role in running a clinic or doing a clinic, we should always ask people if their phone number has changed. And not just that, but ask them, is there someone else we can call to get a message to you? Is there someone else who would know your phone number had changed? Because is there another message that we can leave if we want to give an appointment reminder? Because people run out of minutes. If something happens, people lose a phone, people run out of minutes and they can't replenish them anymore. Another thing is helping people get free phones. Have people heard of Obama phones? So they're called Obama phones because the program's grown a lot. It's actually an FCC program that is paid for through fees to the cell phone companies. It's existed since the 80s with landlines, but it's a program that people can get free phones through specific companies and about 200 minutes of free minutes and otherwise low cost phones. So making sure that people have access to that and telling them about that is another way that we can make a difference. And then thinking about when and how should we support people in keeping phones, or having a Google Voice number, or whatever other things that we can do to kind of make sure that people have access to a phone number where we can reach them, or if we can't reach them, another way to get in touch with them. Because I know that I wouldn't make it to a lot of medical appointments if I didn't have the calendar on my phone and a reminder 2 days before. So it's just something for you to keep in mind in your work. Are we doing questions or not doing questions? Okay.
Our next 3-minute thesis presentation is going to be Stephanie Davidson, who is going to be talking about the cost-effective promise of complementary care.
Good afternoon, everyone. The Agency for Healthcare Research and Quality says that in 2010, $58.6 million was spent treating hypertension at an average of $733 per case. That comes out to a total of $42.9 billion. That average number was higher in Hispanics and Blacks, almost $150 to $250 higher average per case. And in a system that's already overstressed and looking everywhere that's possible for resources, if we could lower those numbers, it'd be in the best interest of all those patients. The Journal of Human Hypertension in 2007 published a study showing that a specific form of complementary alternative care showed a decrease on average of 17 systolic and 10 diastolic in blood pressure, and that change was sustained over 8 months following the care. And my understanding is that that is equivalent to what we expect to see from a 2-drug therapy, which is considerably more expensive, as I just read you. A reasonable estimate says that the cost for the care that was in that study would be $576 a year, as opposed to the average of $733. And times 58.6 million people is a number that my phone calculator didn't want to give me. It was to the 11th power of something. And additionally, also in 2007, in the Journal of Manipulative and Physiologic Therapeutics, there was a study showing that a cohort of patients who used complementary and alternative care as their primary care received 60% less inpatient care, 59% fewer hospital days, 62% less outpatient surgeries, and 85% less pharmaceutical costs. And I think that historically there has been a barrier of one kind or another between what's considered mainstream care and complementary care. I think probably largely because of research that was not available. That research, as I've just read a little bit of, is now available. And I think that the purpose of my giving a talk today was that I want to encourage us as students that we would break down that barrier, that whatever the research has shown to be safe and effective, that we would embrace that for our patients, and also through our advocacy efforts and working with policymakers, that we open the door for whatever is going to be best for our patients and for the system. Thank you. All right, thanks so much to our presenters. Again, if you have questions for your presenters, you can ask them during the break. We're going to take about a 10-minute break before we proceed to our talk with Dr. Brawley. During that break, the restrooms are over to the right. I think the men's, I think, might be to the left or your right. And then if you want to get some food, we have plenty of food left, so please grab some more in this room over here. But again, we're going to take a 10-minute break, and then we'll direct you to the room where Dr. Brawley will deliver his keynote address. Thanks so much.
Huh?
Are you moving rooms?
I think so.
Yeah,
He is professor.
good speech.
I forgot to say research. You should ask about it in research.
Student at theses are
Yeah, I was like, I don't even know if it's true, but I was like, I'm so surprised. Well, also it's like very hard to like know how to do a search for it, because like if you search your cell phone, like there's tons of studies of the like interventions for cell phones or messaging, you know. So there's things I've forgotten to say. But like there's, you know, like, but I think that
what
like,
you say on the mHealth, like the way that people are trying to move.
yeah,
Like,
because
is it?
and like, what if some patients, like for a lot of people, it might be better to get a text message than a phone call because they're cheaper. But like, do we have that capacity? I know that we don't necessarily at Emory have the capacity to like text people from phones that are private phones. So like, there's plenty of computer that you can text people on. So like, if people don't have minutes, you can still get to. And the other thing is like people leave jail, like.
Yeah, and then when the number changes, and that doesn't help you. Like if you text them, you'll never know.
Yeah.
Well, if you called, you would be like, oh, you're
Number change, yeah. And I think that's part of the thing is like, what do you do? What's like our obligation when the number changes?
yeah,
Like,
that's true.
because, but also like, if it's, so right now, if your number changes and you're a gritty patient, like, can you call and say my number changed? Like, no.
Yeah.
Like, you're not going to reach anyone.